Let's talk about collaboration for a while, and I'm going to try to be short and sweet as I know this is getting to be a longer week for everybody. Collaboration is one of the other competencies that you're going to be utilizing quite a bit as an APRN. Obviously, for the nurse practitioner, we tend to collaborate a lot in the hospital setting or the acute care setting with physicians. As a CNS, collaboration is a very important part of what you'll be doing. When we talk about this, it very much ties into leadership. So, collaboration is a process by which the nurses come together with patients and other healthcare members and form a team to solve a patient care or healthcare system problem, with members of the team respectfully sharing knowledge and resources. True partnership, in which there is a valuing of expertise, power, and respect for all members, recognizing and accepting each participant's sphere of activity and responsibility, and requires a sophisticated level of communication. As an APRN, we practice in an area that's highly complex, right? That acute inpatient or the acute even outpatient realm. This requires us to really work in collaborative relationships. These are often reciprocal relationships that can include the patient, the family, other healthcare providers, or anybody that's involved in the patient care. Patients assume that their healthcare providers communicate and collaborate effectively. And if they hear that that's not occurring, patients not satisfied with that. Patient dissatisfaction then with their care leads to unsatisfactory clinical outcomes and our frustration as well. And this can often be traced to a failure to collaborate among those caring for the patient. Sometimes in what I was just talking about, you could substitute the word communicate, right? A failure of communication amongst team members, and that leads to breakdown of the process and poor outcomes. So I often think of communication as a almost sometimes you can use the word communication instead of collaboration. They're very similar. But collaboration is really this reciprocity of acknowledging our role and the other people's role and having respect and equal respect for each other. So in order to have good collaboration, that will depend on clinical and interpersonal expertise and strong collegial relationships. The primary focus we're going to talk about then is that how do we work amongst individuals and as teams that we can make sure we are understanding each other's values, understanding each other's behaviors, etc. The definition that we talk about here from Emich in 2018 really shows that collaboration is an interactive environment or term, right, that talks about putting together how we communicate with each other. It's also about how we behave with each other as well. So we have to have teamwork, but also respect each other while we're sharing our knowledge and our resources. Working together to solve the problem for the patient includes the notion that collaboration is a process that will evolve over time. Functioning is a learned part of an interprofessional team and is not always inherent. So positive attitudes can influence behaviors that can enhance accession of the collaborative expertise. The ability to communicate in this interprofessional realm is not easy for some people. It can be pretty challenging. There's 4 competencies of collaborative practice for health professionals: values, ethics, roles, responsibilities, communication, teamwork across the full spectrum of care. The triple aim framework to improve patient experience of care is quality of and satisfaction with your care, improving health of populations, and reducing per capita cost of the healthcare. It's also important that we acknowledge that in collaboration, there will be experiences that are not always pleasant. People will have disagreements. So the successful collaborative relationships develop strategies for dealing with disagreements that are mutually satisfactory and enhance the process for everybody. Collaboration in and of itself is a competency, like I said, and really involves communication, and it involves a sophisticated level of communication. This means that really collaboration is not easily legislated or regulated because it's very organic and how different parties are going to be able to work together. It's really also important to talk about what collaboration is not, okay? So there are several forms of interaction that occur between us as clinicians and other clinicians, other patients and families, administrators, etc. But there are times that there can be confusion as to what collaboration is. So the first one that it is not is parallel communication. Parallel communication is this form of functioning in which the clinicians interact with the patient separately. They do not talk to each other before seeing the patient, nor do they see the patient together. Parallel functioning of various interprofessional advanced practice roles can lead to competition rather than collaboration, and this creates ineffective and expensive patient outcomes and situations. There is no expectation of joint interactions. An example that the reading in the book that I'm using talks about is that the staff registered nurse, a med student, the attending, and the ACNP all ask the patient the same questions about medications. In that example, there were multiple interactions that are burdensome and frustrating for the patient, right? That's when you get your patient saying, I've already talked about this with like 6 people. So these types of interactions may confuse the patient, and you get this fragmented information leading to errors in clinical decision making. So the patient expects that at least at a minimum, the information will be captured in the record, and all those involved with the care will read that record and understand that information. The next one they talk about a little bit here is this parallel functioning. That occurs when the providers care for patients addressing the same clinical problem, but they don't engage in any joint or collaborative planning or discussion. So an example would be if you have a patient that has their nurses, the physical therapist, and then the physician, all of whom document their interventions for pain in separate parts of the record, and they don't communicate about it. But in collaboration, the interprofessional team members can use a tag team approach to gather this information that can then be shared successfully and make things more efficient, and therefore you're getting better outcomes. One-sided compromise is communication that demonstrates a one-sided compromise. For example, when the APRN is overly agreeable, consistently yields to other healthcare providers and demonstrates a personal lack of responsibility in the care. This yielding results in compromised care and occurs when the APRN lacks the willingness or the skills needed to engage in a collaborative negotiation. When you develop one-sided relationships, these are linked to insufficient knowledge sharing between the professional teams, and that leads to a hierarchical structure of professional relationships with physicians that ultimately result in unclear treatment plans for the patient. Faux collaboration occurs when persons in positions of authority believe they are being collaborative because those around them are agreeing with the authority figure but not engaging in meaningful dialogue. This form of communication can be rather subtle and difficult sometimes for others to understand. So barriers of your hierarchical vantage points and professional territorialism have caused the interprofessional collaboration to develop slowly in healthcare, right? For many years, we definitely had this hierarchy and you had to stay within that. So when we've moved past this in our quest for collaboration, interdisciplinary teams, interprofessional teams, we're breaking down that hierarchy and breaking down the territory issues, and that can be kind of hard. So the true nature of this IDT type of vision requires shared leadership to achieve common goals that are beneficial to all team members. Collaboration is not information exchange. So informing may be one-sided or two-sided and may or may not require action or a decision to be made. But if the action is needed, the decision is unilateral and not a result of joint planning. So the information exchange may be sufficient and you could get a beneficial outcome, but there's a risk of yielding a negative outcome because if the situation requires you guys to be working together, then that's not going to work so well. Communication is the key competency that healthcare professionals need for effective collaboration. Collaboration is not just simply coordination. So in coordination, that's when this form of communication lends structure to the encounter and may include actions to minimize duplication of effort, but not interaction. So the example given was the Canadian Interprofessional Health Collaborative developed the practice model, which demonstrates how patients cared for benefit from the one-stop shop approach. So in this Canadian council that they came up with, it allowed the providers to devote more time to patients, which would facilitate more thorough care. For another example, though, would be we coordinate a lot as APRNs. Maybe we're following up with the pharmacy to make sure they receive the medication. And that, again, that's communicating well, but that's not necessarily a form of collaboration. Consultation is not collaboration. When you're a consultant, that is the clinician who is caring for the patient seeks advice regarding a patient's concern, but retains primary responsibility for the care delivery. So if I consult physical therapy, that doesn't necessarily mean I'm collaborating with them, but I'm consulting. So consultation and collaboration allow us to work well together, but we have to be careful they're not exactly the same thing. Also, co-management is not the same thing. That process is when consultation comes in, and so they're managing their part, I'm managing my part, but it doesn't mean we're necessarily collaborating. Same thing with referral and same thing with supervision. Some people think that collaboration equals supervision. Not true. Supervision means when one clinician delegates aspect of the care to another, but retains the full authority for the care. So authority and accountability for all aspects of the care, which include conducting the billing process, are retained by the supervisor. Collaboration is also meant to be mutually beneficial for all and accomplish common goals. So this is the meaning of shared leadership that is the hallmark of collaboration, not supervision. APRNs are autonomous practitioners, therefore supervision of them by other disciplines is not appropriate, nor is it appropriate for APRNs to supervise other disciplines. APRNs may supervise other nursing personnel regarding aspects of the nursing care that they provide. So the domains of collaboration as an APRN, we execute the collaboration competency in several domains: individuals, teams, organizational, global, arena. I don't think we need to go through that in great detail. The terms of collaboration is when we kind of talk about this multidisciplinary, interdisciplinary, transdisciplinary. Those terms are all listed here. It's hard for me to keep them separate because I tend to use them interchangeably. Interprofessional collaboration occurs when more than one professional works together on a particular health problem, and it's been central to the delivery of improved healthcare and is recognized as essential by big organizations like the World Health Organization and the Institute of Medicine. Several forces have come together to foster interpersonal collaboration. The WHO and the IOM, for example, have encouraged healthcare professionals to improve their delivery by joining together through this collaboration. The need for collaboration has led to more specific interprofessional competencies. So when we talk about, I don't need to go through all of that with you guys. Characteristics of effective collaboration: clinical competency and accountability. We have to have a common purpose, interpersonal competence, and effective communication, recognizing and valuing diverse complementary culture, knowledge, and skills. Some characteristics of collaboration have long been recognized, but clinicians and organizations sometimes still resist adopting the necessary philosophy and the commitment and this culture of change. They, in the text reading that I didn't print off for you guys because I didn't want to overwhelm you on your reading, they talk about the four characteristics of effective collaboration are development of role clarity, interprofessional trust and confidence, possessing the ability to overcome adversity and personal differences, and collective leadership. So in this collaborative environment, members have a duty to perform your role that's unique to you, with the success of the team being the focus, which is a little bit different. Without a collaborative mindset, then you're trying to perform your duty, but the success is focused on what you're doing. Whereas when you're in a collaborative relationship, the success is the success of the team. But you have to be confident in your own abilities as well, and the team needs to trust that you're competent in your own abilities. And it's hard because we are people and we don't always get along. Personal differences have to be able to be set aside, though, and work for what's good for the interest of the patients. They do put humor on here because a good sense of humor goes a long way to having people work well together. I totally agree with that. So the clinical competence and accountability, perhaps the most important characteristic is truly this clinical competence and being accountable for what you're doing as part of your team. Without it, the trust and the desire to work together really just falls apart or won't even develop at all. And the trust and respect are built on the assurance that each person in this team is able to carry out their roles and they're competent and they're accountable, right? You have to be able to trust that if you say Sarah's going to go in to do her part, that I know what I'm doing, I'm going to do my part, and I can be accountable for that. Otherwise, you're not going to trust me. Clinical competence is a basic element of collaboration, yet stereotyped views of nursing or medical practice can sometimes interfere with this. Sometimes that an example of this could be like physicians may still feel they have the ultimate responsibility and nurses always have little responsibility. That would obviously impair our mutually working well together. Contemporary leadership shifts among partners in a departure from the traditional captain of the team approach when you're working in collaboration. So the trust and respect among all of the collaborators are such that they can count on the satisfactory resolution of the problem, even when they know as individuals that they may have to approach the issue differently. And this is an open idea, an openness to change. And this openness to the shared leadership and alternative solutions is really a key component as well. Having a common purpose is an essential requirement to be in a collaborative relationship. The goals can be a starting point for identifying the purpose of your collaboration. Partners are autonomous but interdependent, and developing a shared vision supports differences among the partners. Interpersonal competence and effective communication. So your ability to communicate effectively with your colleagues, right? And this is what we're talking about. Key is to communicate openly, clearly, and convincingly, both orally and in writing. Transparency is being honest and open sharing of information and ideas. And assertiveness is a key element. It can be very intimidating to be in a room full of people talking about something and you be not in the majority, that you have you're not agreeing with everybody. You have to be able to be confident and assertive enough to say your part. And like right now, what I do a lot, obviously, is hospice. And in this times, if I'm in the hospitals and I'm part of this interprofessional team talking about what's in the best interest of the patient, I find myself often where I would say, I think the patient is ready for, or it would be eligible for hospice. And I get people that don't agree with me. They think that we're, we could still try this and we could try that, and it's too soon, and we're quote unquote pulling the plug too soon. And well, I don't agree with that. I don't think we should give up just yet. And I can find, I'm in a room with a PT, a OT, a speech, a med student, the nurses, maybe the respiratory therapist or whatever, and people very much being against what I'm trying to say. And it's intimidating a little bit because I have to be able to assert myself and to be open in my communication. And I've had to learn to say things like, I hear your point and I appreciate your point. I think you're bringing up very valid points. I also want my side to be heard, and I'd like the chance to explain what I'm saying. Or I think what's most important at this point is we look at this from the perspective of the patient. Or I think this is the right thing to do. This would be my suggestion, but I am open to hearing what you have to say, and I appreciate the opportunity to have this environment where we can share our opinions safely and non-judgmentally so that we can come to a consensus of what we would recommend for this person. But that effective communication is really key. Recognizing and valuing the diverse complementary culture, knowledge, and skills. Also very true. You have to be able to accept all the people on your team that you're collaborating with, and you must believe that the complementary knowledge of these other team members will enhance the plan for the patient care. Collaboration built on respect and valuing of contributions of each profession to the common goal of the optimal healthcare delivery for each patient. Again, humor. Humor is which intent is positive and non-threatening. It can help improve patients' well-being, but it serves to decrease defensiveness, invite openness, relieve tension, and deflect anger. And I know it's kind of like, okay, humor, yeah, yada, yada. Humor is so key. I resort to humor very, very frequently. And although the work we do is always serious, there's always some room now and again for levity. There's actually been studies done about humor in healthcare. In 2015, there was a study that suggested that nurses can influence the care delivered to patients and improve their well-being just by using humor. It decreased stress and made the relationship between the nurses and the patients less tense. Positive and non-demeaning humor, though, is the key, and that can help create and facilitate communications. It's not poking fun at somebody else in the room or poking fun at someone you all mutually don't like, but cracking the joke in the middle of the tension is a very legitimate way, an appropriate joke to help cut the tension in half and just have everybody kind of simmer down. And then you can feel a sense of connection. Appropriate humor is the key, though, right? The impact of collaboration. And this really cannot be undermined or talked about too much. It is incredibly impactful. So on the patients, it has been shown, this has been studied time and time again, we are improving patient quality of care, patient satisfaction, and we're having better outcomes, you guys. We're actually lowering mortality. And if you think about it, we've seen this in a variety of ways when we study different things in healthcare. So, for example, would be, I don't know if any of you have done much about this, but in the OR now, there's this big push that they recommend in the OR that you introduce each other by first names. And that means that even the anesthesiologist, Dr. Smith, and the orthopedic surgeon and the neurosurgeon, what have you. But the surgeon would say, I'm Kevin, and the anesthesiologist would say, I'm Sally. And they go around the room and they introduce themselves as equals in the terms of all being in this collaboration to care for the patient and the surgery. And the idea being is that if I'm a nurse or a surgical tech or someone who's not the physician, I then feel more valued as a team member, and I feel more capable of saying something when I feel like there's something. So if I saw something, I can speak up and say, Sally, did you see that? Sally, have you noticed this blood pressure trend? What have you? We're improving patient outcomes because we're able to speak up more freely. We are empowering the patient and the family as well to speak up and say things as well. Providers, we have improved trust and respect for our fellow caregivers. We have better communication. We share the responsibilities and the expertise, increase personal satisfaction, our quality of our professional life, and we can feel more empowered to be part of the team. Research supports it, you guys. There's a lot out there. If there's ever anything you want to do in terms of some of your capstone stuff and the research that you're going to be doing further down the line, support of collaboration as a competency is something maybe you guys want to look into. It's rich in research. We know that the impact on health outcomes is there. NPs are effective in managing health conditions and are cost effective. We know that when physicians and APRNs can collaborate, that's better. And that we know that when we don't collaborate, we see failure, harm to patients, and increased morbidity and mortality. The imperatives for collaboration are listed here: ethical imperative, institutional imperative, and the research imperative. Context of collaboration in contemporary healthcare. Transition to more accessible, effective, and efficient care may actually change collaboration. The confusions about scope of practice can be damaging for all. Listed here is this confusion about the scope of practice, and what they mean by this is other professionals or other providers could find themselves saying, why should I collaborate? What is it that I'm going to gain? What areas of my work do I get to expand because other providers can do things that I have always been able to do? So there could be some confusion sometimes into who's doing what. APRNs can be uncertain about how to proceed with collaboration. For example, when you're asked to assume a responsibility for a new skill, maybe an invasive procedure, the reality is that regulatory initiatives and payment structures are rearranging collaborative relationships frequently. So maybe you are credentialed to do a procedure, a central line. And in order to keep your credentialing and to keep that privilege, you have to do 10 a year. Well, maybe you work in an environment with med students and residents that are coming through all of a sudden. And so now they're doing all of the invasive procedures and you're kind of stuck with, well, I need to do at least 10. And how do you navigate that, right? Those regulations and things now can be kind of a challenge when you need to say, hey, I need to be able to do some of those things now. And if I co-sign on yours and walk you through how to do it, then I don't get to bill for it. And if I can't bill for it, then I'm not recognized as having done it. So, sometimes you have to work through some of these things. Incentives and opportunities for collaboration. Many guidelines around interdisciplinary teams specify that this interdisciplinary collaboration has to be done because it's all of these positives. Like we've said, it's improving outcomes, keeping costs down, et cetera, et cetera. But standards and guidelines developed and agreed upon by interdisciplinary groups, whether at the local, national, et cetera, can be really hard to agree upon, right? When you put a bunch of cooks in the kitchen, how are you going to come to a consensus of how you're going to define something? So there's other things that are trying to help give us standards. The Joint Commission requires documentation that demonstrates collaborative interdisciplinary practice to help provide and develop stronger interdisciplinary approaches to care. So they came in and say, you have to have something in your medical record that shows you're using this interdisciplinary approach or interprofessional approach in your healthcare system. There's also, let's talk about, wrapping this up, barriers to collaboration. So implementing effective collaborative relationships can be very challenging. Like I said, sometimes we may have good intentions and then these other environmental factors come into play, and it can be really tough to actually come to fruition, is what I would say. There's disciplinary challenges. Each profession is a culture within its own world, right? That have our own values, rules, etc. And those worlds are frequently conducted at different types of institutions, allowing little opportunity for shared learning. This last summer, in the first cohort of this program, in one of the immersions, we actually did an interdisciplinary immersion where we actually had, at that time, the social worker come in and do some stuff with us. And that was kind of the first time where we shared this learning opportunity. And we've talked about, is there benefit to even at the school level, like with you guys, to have interaction with physical therapy, social workers, case management, those kind of things. But would it be beneficial to all to bring in a simulation where we have social worker students, pharmacy students, and physical therapy students, for example, come together? The challenge is that oftentimes they're in different buildings, totally different, unrelated programs. But if you're at a university that would offer all of them, like Augustana, could there be a realm when that would be a possibility to start practicing collaboration? But there's other parts about that it's especially about this culture, our way, how we do things, that can be really um, challenging. Each discipline in and of themselves has their own unique things, and that can be kind of tough to come to a mutual understanding between the disciplines. So one discipline may firmly believe that they are the only ones that can do this certain thing for the patient. It's their territory, it's their world. And that would be really hard then for them to accept a collaborative part where maybe somebody else also can do that same skill or survive in that same territory for them. The Robert Wood Johnson Foundation Partnership for Training initiative from 2012, I think, identified many of the stresses inherent in building and sustaining this IDT community or these interdisciplinary partnerships. There were still stressors by everybody, right? So it was different agendas, different systems that weren't integrated, varying philosophy, and then just this I am stuck in my way of how I think this should be doing. Ineffective communication and then team dysfunction. If you have someone on the team that can't have the maturity sometimes to work well as a group, or again, can't let go of their own biases or their own beliefs, and they're so disruptive, or people that are not good at their job or dysfunctional in their role, very quickly, if you don't have that trust, that is definitely a barrier to having an effective collaborative team. Again, the socio-cultural issues. This can still happen. It's like it's America, right? But this does happen. You can have people maybe that are from a foreign country that are here on visas or work studies, and you will, or people that are just still from wherever they are at in their own personal life. They don't want to work with a woman. They don't want to work with a man. They don't want to work with old or young or people of different ethnicities. That can still come around. Then there's the organizational challenges from state to state and regulatory challenges, etc. Some of the things that we know help create effective collaboration: recurring interactions, effective conflict negotiation, and resolution skills obviously are very important. Um, Partnering and team building can be very important as well. That really can help solidify your team and help things go well. In the text that I was looking over to for this talk about some of the conflict resolution skills, having a win-win approach, being creative in your responses, having a good sense of empathy, having appropriate assertiveness, cooperative power, meaning everybody shares from the same power base and we don't have someone who says, well, I have the power over you, ergo you have to do what I say. The ability for us to have emotional intelligence in managing our own emotions, willingness to resolve issues, development of options, introduction to negotiation, mediation, and just people being able to have broadening horizons. Sorry, those on there. Wrong slide. Okay. So these are the things that you guys can use now to begin to build your self-reflection growth and think about these things as you're getting out there into practice. Am I clear about my role in the partnership? What values do I bring to the relationship? What do I expect to gain? What do others expect of me? And I would encourage you guys to think about this as you are in your RN world. Have you been part of an interprofessional team and felt, I don't feel confident or competent in this dynamic we have going on, or I don't feel respected, or those things? So these are some of these questions that we can begin to ask ourselves as part of being self-reflective and aware. So how can we help contribute to being successful and having successful collaboration? We can work on our individual strategies, right? So us as individuals, we can be respectful, professional, we can listen intently, we can try to understand the other person's viewpoint before we express our opinion, model the attitude of collaboration, and do it every time, every day, and have that just be the standard. Decide what is negotiable, what is non-negotiable. Participate, be part of the groups that are looking at these things. are there quality improvement initiatives or things that are happening, evidence-based guidelines, councils, be part of collaboration within your facility and lead by example. Then there's the team strategies, right? Our primary focus for groups is to develop the effective team and improve the healthcare quality. APNs should model collaboration in all interactions and expect the same. And then kind of pushing this idea of the group visit by collaborative group of providers. Organizational strategies. There are numerous initiatives to improve safety and quality, facilitate collaboration. Magnet requirements for magnet hospitals require evidence that you have these interprofessional teams. And there's really a strong move right now that we are learning interprofessional collaboration in the educational programs. We talked about those. So in conclusion, obviously, radical change is needed if the conditions conducive to collaboration are to become the norm. As an APRN coming out into practice, whether you're a CNS or an NP, collaboration is going to be key. You have, sometimes I always say, a foot in nursing, a foot in medicine. You're kind of navigating both worlds. You collaborate, and inherently it's woven into what you do. Collaboration is woven into your leadership skills as well. And you guys are going to find yourselves almost automatically in some kind of situation, whether it's very small, right with a patient and nursing or something, or even if you get into administration or bigger levels of it, you're going to find yourselves in collaboration and chances to lead by example and to also mirror leadership and collaboration through your direct clinical care. I didn't want to spend too much time on this one because it was fast and furious. If you guys wanted the chapter from the book copied out as a PDF and sent to you, please let me know. I'd be happy to give that to you if you feel like that's something that would be helpful for you to have in the future moving forward. So thanks for hanging in there this week, and I look forward to your guys' discussion. Take care.